Today I'm going to talk about another very important and interesting topic, that's shortness of breath in adults. This is part one of this lecture. In the other part, we will explain about some diseases, while in this part, we'll talk about how to approach a patient with shortness of breath. So, moving on, shortness of breath in medical terminology, it's called dyspnea. How do you define dyspnea? In simple words, is feel for air, hunger for air. Dyspnea itself is a very common terminology, but it has various disastrous effects in a patient when you come across a patient with shortness of breath in emergency department. There are a few other terminologies that are used with shortness of breath, for example, orthopnea, that is increase in shortness of breath on lying down, most commonly present in patients with congestive heart failure. Dyspnea, on the other hand, is a subjective feeling. You cannot, while working in emergency department, one cannot identify the cause of dyspnea because it is so irritable the patient is that you have to immediately intervene and to stabilize the patient first. As I said, dyspnea is a subjective complaint. How do you assess a patient is going into respiratory failure? Dyspnea is a common presentation, but how do you classify patients who are with mild dyspnea or patients who are with severe dyspnea? For example, using of accessory muscles, increased respiratory rate, cyanosis, unable to complete a sentence. These are signs of impending respiratory failure, and this needs an immediate intervention. Either that may be a simple oxygen supply or a mechanical intubation. But before going into the details of the history or what might be the cause of the dyspnea, you have to protect the patient first. You have to maintain the airway, you have to stabilize, you have to maintain the oxygen saturation inside the body. So, some anatomy. As you know, the respiratory passages include nose, oropharynx, trachea, and the lungs. There are two types of receptors present in the respiratory system. That is mechanical receptors, which are stimulated by the muscles and mechanical support of the respiratory system. While on the other hand, there's a few chemical receptors, they are present in blood, which are stimulated by the changes in carbon dioxide levels, oxygen level inside the blood. Most commonly, there are two types, carotid bodies and aortic bodies, which are presented over here as this cursor is moving around here. So to know the anatomy of the respiratory system is very important, because this helps you to examine the patient according to the respiratory system. For example, a patient presenting to you with stridor or abnormal breathing sounds. Think of any foreign object. So by looking into the mouth or oropharynx, you can identify is there any foreign body present or not. And this you can help to evacuate and relieve the dyspnea of that patient. So, before moving on to red flag sign, let me give you an example. When you see a patient who is known case of asthma, he presents to you in emergency department with shortness of breath. He is unable to speak. His respiratory rate is more than 30. He's cyanosed, or he is using accessory muscles. What would you do? The first and the foremost thing you would do is oxygen supply. Give that patient oxygen without even taking the history from any caretaker around him or any parents or siblings or anyone who brought him to the emergency department. First, give that patient oxygen, because these are the signs of impending respiratory failure. And if not treated adequately and timely, this patient can go into respiratory failure and eventually into death. So in this slide, I will explain about some of the red flag signs that you can come across while working in emergency department. So a little history, you can take a few seconds to take history from the caretaker or the person who is next to that patient. Altered mental status. This is a very, very important sign. And this is a sign of impending respiratory failure. What might be the cause of altered mental status? Hypercarbia, increased carbon dioxide inside the body, can lead to altered mental status. Poor oxygenation can lead to altered mental status. This is a very important thing to notice in a patient with altered mental status. Decrease in Glasgow Coma Scale, that GCS, less than 8 is an indication for endotracheal tube intubation. So when you see a patient with severe dyspnea or altered mental status, look for GCS. If it's less than 8, mechanical intubation is required. Hypoxia. Hypoxia due to hypercarbia, because increase in carbon dioxide levels dissociate oxygen from the hemoglobin, leading to hypoxia, tissue hypoxia, and eventually organ hypoxia. Somnolence and decrease respiratory rate or increase carbon dioxide levels. So as I mentioned a few seconds ago, increase in carbon dioxide can lead to altered mental status. Hypercarbia, increased accumulation of carbon dioxide inside the body. Chest pain, another very, very important sign. Why it is important? Because chest pain gives you clue about two things: cardiac hemi, myocardial infarction, pulmonary embolism. We'll talk about the diseases in details in the next lecture. That's a part 2 of this lecture. But for now, the common emergencies that you come across with the patient presenting to you with shortness of breath, with this red flag signs, you can think of things what I'm talking about: chest pain, myocardial infarction, pulmonary embolism, any new onset ischemia, cardiac ischemia, respiratory failure or pulmonary edema due to a left ventricular failure. The chest pain is very, very important sign. Again, acute coronary syndrome or pulmonary embolism. At times, pulmonary embolism is hard to differentiate because patients present to you with sudden onset of a shortness of breath. You auscultate the chest, you find nothing. Tachycardia. There might be a history of pulmonary embolism or deep venous thrombosis or not. There can be a history of thrombus in the heart and the cardiac chambers, but you are not aware of it. But if a patient comes to you who's bedbound, bedridden, with risk factors of pulmonary embolism, with tachycardia, tachypnea, chest pain, hypotension, think of pulmonary embolism. Pulmonary embolism is fatal if not treated adequately. Sudden onset of shortness of breath. This can be due to pulmonary embolism. Acute exacerbation of asthma. Patient with a history of asthma, especially in winters. There's increased flu-like symptoms which exacerbate asthma. Similarly, in a patient with chronic obstructive pulmonary diseases, these can present to you with sudden onset of shortness of breath. Pneumonia can at times present to you with sudden onset of shortness of breath. Congestive heart failure can present with sudden onset of shortness of breath. Pneumothorax, as air in the pleural space, can present to you with sudden onset of shortness of breath. So pneumothorax can be due to a trauma, tension pneumothorax, which includes tracheal deviation to the contralateral side, distended neck veins, hypotension. Or pneumothorax can be due to spontaneous pneumothorax, any bulla that is present inside the lung parenchyma or lung cavity can present with pneumothorax, that is spontaneous pneumothorax. Mentioned before, pulmonary embolism, acute coronary syndrome, congestive heart failure, or anaphylaxis. Anaphylaxis can present with various symptoms. For example, a skin rash, a generalized edema, or generalized redness of the skin, of the facial skin. There might be a history of new drug intake. There might be a history of any allergen, but necessarily it's not always the case the patient presents to you with an anaphylactic shock. So you have to manage the patient with sudden shortness of breath. And what to do give first? Oxygen, oxygen, and oxygen. Syncope, acute coronary syndrome, dysarrhythmias, valvular heart diseases, cardiomyopathy, and pulmonary embolism. So we'll talk about in detail when you come to the section of history taking, why these symptoms are very important. When you take the history, this can give you a clue that this patient might be having this kind of diseases if they have these symptoms. Orthopnea, PND. Again, as I mentioned in the previous slide, orthopnea is shortness of breath on lying down. It is commonly in patients with congestive heart failure with decreased cardiac output or decreased ejection fraction. For example, a patient comes to you with shortness of breath and he's stable enough to take the history, and you ask the patient, how many pillows do you take while sleeping at night? If it says 2, think of PND or congestive heart failure. If the patient tells you there is increased air hunger and warrants a patient to wake up while during a sleep, sign of PND. So PND, congestive heart failure. Age more than 50 years, think of cardiac and pulmonary abnormalities. For example, a patient with history of smoking, he's elderly, present to you with shortness of breath, and you auscultate the chest, you find creps and wheeze. What should be the differential diagnosis? Chronic obstructive pulmonary disease. A patient with elderly, known case of diabetic, hypertensive, or multiple risk factors, or history of ischemic heart disease, present to you with shortness of breath. Look for congestive heart failure. Look for any pulmonary embolism. Cardiac and pulmonary diseases. So what cardiac diseases could be in the patient with advanced age? Heart attack, MI, dysarrhythmias, atrial fibrillation, new onset to be precise. Pulmonary diseases, what includes pulmonary disease? Chronic obstructive pulmonary diseases, bronchitis, acute exacerbation of asthma, pulmonary embolism, or history of DVT of patients who are bedbound, pulmonary embolism. These are very, very important differential diagnoses when you come across a patient in emergency department. So, reviewing again, when you come across a patient with shortness of breath in emergency department, irrespective of what might be the cause of shortness of breath is, the take-home point is give that patient oxygen. So, coming on to history. I talked about some of the red flag signs in the previous slide. History is very, very important to help you to differentiate and to diagnose the patient, or at least identify the cause of the shortness of breath or respiratory failure. But before going to the history, you have to exclude the red flag signs. Red flag signs should be addressed first. A patient comes to you with dyspnea, shortness of breath with red flag signs, or there is an increased chances of impending respiratory failure. How do you treat? Give that patient oxygen. Oxygen is very, very important. What should be the oxygen saturation in the patient with impending respiratory failure? More than 90%. You have to keep the saturation above 90%. And in some literature, it is said more than 94%. On the other hand, the patients with COPD, they are chronic hypoxic, so they can tolerate around to 88 to 92% of oxygen saturation. So what do you do when you see a patient with shortness of breath? First thing, give this patient oxygen. Maintain the airway first. Then get in ABGs, arterial blood gases. Look for PO2 levels. Look for respiratory acidosis. Look for pH, carbon dioxide, PO2 levels, and bicarb. This will be taught in details in the next lecture. But why ABGs is important? Because if partial pressure of oxygen is less than 60 millimeter of mercury, this patient is hypoxic. Give this patient oxygen. If there is respiratory acidosis, if the pH is less than 7.1 or 7.2, this patient might need NIV, non-invasive ventilation, or endotracheal tube intubation. If a patient is retaining carbon dioxide levels, give this patient a try of NIV, non-invasive ventilatory support, just to wash out this carbon dioxide, because this can cause hypercarbia and this can cause altered mental status. And at times, this reflects feedback from the central nervous system, can lead to decrease or slow respiratory rate, further accumulating carbon dioxide inside. So why this was important to tell you before going into the history, because this should be addressed first. While working in emergency department, you have to address the emergency condition first. Flu-like symptoms, fever, history of cough is irrelevant in a patient who comes to you with shortness of breath. But shortness of breath with life-saving or impending respiratory failure should be your concern. If the patient is vitally stable, airway is maintaining, he's talking to you, relax, calm down. But if a patient is unable to talk, he's using accessory muscles, respiratory rate is more than 35 or 30, think of impending respiratory failure. That needs to be addressed first. So moving on to history, how did the shortness of breath begin? Was it gradual in onset and reactive airway diseases? Especially in the patients with congestive heart failure, they can present to you with gradual onset of respiratory shortness of breath. Patients with neuromuscular diseases can present with gradual onset of shortness of breath. Was there any sudden shortness of breath? Sudden shortness of breath includes pneumothorax. History of any trauma, look for tension pneumothorax. What do you see in tension pneumothorax that differentiate from other type of diseases of pleural spaces? Distended neck veins, tracheal deviation to contralateral side, and hypertension. Is the patient asthmatic? History of asthma or new onset asthma can present you with sudden onset of shortness of breath. Patient with COPD and recent infection can present with acute onset of shortness of breath. Congestive heart failure can present with acute or sudden onset of symptoms. So a simple question can give you an idea, or at least a differential diagnosis, or narrow down the differential diagnosis of when a patient presents to you with shortness of breath. So let's review. Sudden onset, look for pneumothorax, pulmonary embolism, ischemic heart diseases, congestive heart failure, asthma. Gradual onset, look for neuromuscular diseases, reactive airway diseases. Have you had shortness of breath before? History of shortness of breath gives you a clue. In a patient with congestive heart failure, with long-standing congestive heart failure, they might tell you they had this similar episode in the past. Patient with asthma can present with acute exacerbation of asthma, but they had these asthmatic attacks in the past as well. Patient with COPD can present with shortness of breath or have a history of shortness of breath in the past. But you cannot exclude the new causes of shortness of breath. For example, acute onset of atrial fibrillation can lead to congestive heart failure or left ventricular dysfunction. Acute MI can present with left ventricular dysfunction and eventually lead to pulmonary disorders or shortness of breath. So, does anything make the shortness of breath better or worse? Patients can tell you in the history about the position they are comfortable when they have a shortness of breath. For example, patients with PND or congestive heart failure, they tell you when they sit down, they feel relaxed because the respiratory effort is minimized. Patient can tell you when they lay down, there's increased shortness of breath and congestion. Also, this patient can tell you that anything with exertion can increase shortness of breath, or while resting or taking rest, shortness of breath settles down. So what does this indicate? Shortness of breath of lying down, think of congestive heart failure. Shortness of breath on exertion, think of asthma, COPD, think of congestive heart failure, or acute coronary syndrome. Patient who gets better while sitting or in a prone position, congestive heart failure. So, what to do when you see a patient with a shortness of breath? Give oxygen, take in ABGs, and prop up. Make the patient of the patient upright and prop up. So this decreases the respiratory effort in the patients and help to calm down and relax for a bit of time, because of any reason that can exacerbate shortness of breath on lying down. So prop up position is recommended in a patient with shortness of breath. Do you have a chest pain? How do you interfere and how do you realize and what to think in a patient with chest pain? Acute coronary syndrome, pulmonary embolism, ischemic heart disease, myocardial infarction, dysarrhythmias, atrial fibrillation, pleuritic chest pain in patients with pneumonia. Chest pain is a very, very common and very, very vital or important question to ask in a patient with shortness of breath. Because if the patient is with chest pain and EKG show and signs of ischemia, think of left ventricular dysfunction. This patient might need diuretics. This patient might need continuous positive area pressure, CPAP or BiPAP levels. This patient might need a mechanical ventilation. So these are the very important questions you need to ask and help you to differentiate and to diagnose a patient with shortness of breath. At times, it is hard to differentiate between a patient with congestive heart failure or shortness of breath solely due to pulmonary disorders. But signs of right heart failure or PND orthopnea, S3 galoprism, distended neck veins, peripheral edema, these are the signs of congestive heart failure. Do you have palpitation or feel of any abnormal heartbeat? Atrial fibrillation. New onset atrial fibrillation is an ischemic heart disease. So new onset atrial fibrillation can present with shortness of breath. And the patient can feel like palpitation due to atrial fibrillation with fast ventricular rate. Or patient with abnormal heartbeat, they can see or they can tell you they cannot sense the heartbeat is regular. They think the heartbeat is variable. So think of atrial fibrillation. Patient with long-standing ischemic heart disease or patient with a history of ischemic heart disease can present to you with atrial fibrillation. Or patient who have a history of atrial fibrillation can present with shortness of breath. Do you have swelling of the lower extremities? Why is this question so much important? A patient comes to you, an elderly patient comes to you with a history of ischemic stroke, and the family tells you the patient is bedbound from the past 2 months. Now, he was all right when he suddenly started complaining of shortness of breath or air hunger. And a chest pain, you receive a patient, you check for the vitals, you see a tachycardia, nothing on chest auscultation, chest pain, and swelling of the lower extremities. What would be your first diagnosis? First thing in your mind, pulmonary embolism. Pulmonary embolism can be small or can be a massive pulmonary embolism. What differentiates between pulmonary embolism that's massive and small? It's blood pressure. Decreased blood pressure or hypotension demonstrates a massive pulmonary embolism. So this tells you how this patient should be treated, what should be given to that patient, and how to treat that patient. But again, it starts off with oxygen. Give oxygen, relieve the chest pain with morphine or analgesics, then go for any anticoagulant or therapy for pulmonary embolism. Similarly, patients who are pregnant can present with pulmonary embolism. Patients who have a recent history of any surgery can present to you with pulmonary embolism. Patients who are taking oral contraceptive pills can present to you with pulmonary embolism. Do you feel faint or did you pass out? This shortness of breath is this is a question very important especially in season of winters. In developing countries where there is increased usage of coals and wood in homes can present with carbon monoxide poisoning and shortness of breath. So how they can present with dizziness, vomiting, vertigo-like symptoms. When you receive a patient, you do the ABGs, you find there's increased level of carboxyhemoglobin. So what does that mean? Carbon monoxide poisoning due to uncombusted carbon dioxide. So how do you treat them? High flow oxygen. On the other hand, increase in carbon dioxide levels be due to altered mental status or patient with neuromuscular diseases that has affected the pulmonary system can retain carbon dioxide levels inside the pulmonary system, which leads to hypercarbia. Hypercarbia, on the other hand, can affect the mental status and decrease the Glasgow Coma scale. So with hypercarbia, what to do? Patient should be given high flow oxygen. Maintain the airway. Maintain the airway is the prime job to do as an emergency physician. Do you have any upper respiratory symptoms, which includes flu-like symptoms, which includes fever, cough, productive cough or dry cough, any throat pain, can present with shortness of breath. Increased tonsil size can present to you with shortness of breath. So upper respiratory infection at times is not fatal. With the patient who have a history or any other pulmonary diseases that can be exacerbated by the upper respiratory infections, that should be taken under consideration. A patient comes to you with shortness of breath. He is known case of asthma and gives you a history of recent upper respiratory tract infection. So think of exacerbating factor, that's upper respiratory tract infection. Are you coughing out blood? Hemoptysis can be a sign of pulmonary embolism, malignancies, infections. Upper respiratory tract infection can at times present with fresh blood. So these are the important signs. Tarry or bloody stools, GI bleed, These can present with shortness of breath due to anemia or blood loss. Important question to ask. Have you been vomiting? Sign of acute coronary syndrome. Vomiting at times in a patient with elderly or poor gag reflex. They can aspirate the vomitus and can present with shortness of breath due to aspiration pneumonia or due to aspiration. So when you examine the patient's oral cavity, you see a vomitus. When you do a mechanical intubation, if required, you see a vomitus-stained tracheal tract. So what you do? Clear all the vomitus. So that patient should not be getting more aspiration because of this vomitus that's been accumulated in the oropharynx or the respiratory passages. Recent unintentional weight loss, malignancy. Patient, elderly, history of smoking, present to you with weight loss and other symptoms and shortness of breath. Think of malignancy. Lung cancers. So moving on, let's summarize what we have studied in history. So, worst with exertion. In the previous questions, I told you, think of cardiac and pulmonary disorders, which include acute coronary syndromes, acute exacerbation of asthma, COPD. There are multiple things you need to think in a patient who tells you or gives you history with shortness of breath and exertion. Hemoptysis, malignancy, tuberculosis, and serious infection. History of malignancy, pneumonia, or other significant infection, for example, pulmonary embolism. History of congestive heart failure, chronic obstructive pulmonary diseases, deep venous thrombosis, or pulmonary embolism. Think of congestive heart failure, COPD, and pulmonary embolism. Fever, chills, and night sweats, tuberculosis, pneumonia, or malignancy. Intravenous drug abuse, alcoholism, and other drug abuse, pneumonia. Mind to tell you, they can present with aspiration pneumonia. The patients who are passed out because of drugs, they can have a sign and symptoms of vomiting that at times can be aspirated because of decreased mental status of that patient. HIV positive, think of pneumonia, pneumocystic cardiac pneumonia, tuberculosis, and malignancies. So, examination findings. Fever. Patient with acute onset of shortness of breath with a history of fever, think of respiratory tract infection. Upper respiratory tract infection can be a cause of shortness of breath. Pneumonia at times can present with shortness of breath. A bacterial infection superadded on the viral infection can present with fever, high-grade fever, and shortness of breath. Low oxygen saturation, peripheral cyanosis due to congestive heart failure, acute exacerbation of asthma, acute exacerbation of COPD. They can present with peripheral cyanosis. Hypotension can present with peripheral cyanosis or decreased peripheral saturations. Low oxygen saturations is always not the adequate or accurate while working in emergency department. For example, a patient with methemoglobinemia can present with 100% of saturations. But ABGs is specific and sensitive. They can tell you or give you an idea of patient's oxygen level inside the blood. Stridor or tripod position, patient with foreign body, especially in children, they can present with stridor. Stridor is abnormal signs, especially on inspiration. So a foreign body stridor is common in children due to ingestion of peanut or any coin or any foreign body. So what to do in this patient? Oxygen, Heimlich maneuver, or oral examination if you can find out the foreign body, or you can manually evacuate. Accessory muscles, use retraction or fatigue. Think these are the signs of impending respiratory failure. So this warrants an extra or immediate treatment to that patient. Central cyanosis, especially central lip cyanosis or buccal mucosa cyanosis, COPD, acute exacerbation of asthma, inability to speak in full sentences, acute respiratory failure. This patient is in impending respiratory failure. This patient needs extra oxygen. This patient needs oxygen, oxygen, and oxygen. JVD and tension pneumothorax, right heart failure. They can present with muffling pericarditis as well. But JVD with history of trauma and hypertension, and think of tension pneumothorax. Treat them in emergency department. If you see a patient with tension pneumothorax, clinically it's evident it's tension pneumothorax. You don't have to go for a chest X-ray. You don't need an imaging. First, you should treat the tension pneumothorax by putting a chest drain, and then you can repeat the chest X-ray, or you can go for an X-ray. If it's clinically significant, the patient is going through tension pneumothorax, do not go for a chest X-ray or a CT scan. Go for a chest drain intubation. Rapid respiration, increased respiratory rate, air hunger. Think of patient is excreting more carbon dioxide, patient is getting less oxygen, and this eventually is an reflex mechanism by the respiratory system to excrete the carbon dioxide and take in as much as oxygen as they can. Distant heart sounds, cardiomegaly, pleural effusion. These can present with shortness of breath, and you can find on examination. Poor air movement. For example, in a patient with flared chest or patient with trauma or tension pneumothorax, you see the disequilibrium in the chest movements. If there is a patient with left-sided pneumothorax, the right side you can see moving, but left side is not moving. So poor air movement. Peripheral edema, signs of congestive heart failure, especially right heart failure. Unilateral peripheral edema, patient with DVT, patients with atrial fibrillation, patients with valvular heart diseases can present with unilateral peripheral edema. Digital clubbing, sign of COPD, acute exacerbation of chronic obstructive pulmonary diseases. Digital clubbing is a sign. Diaphoresis, signs of MI. Profuse sweating, chest pain, signs of acute myocardial infarction, acute coronary syndromes. So, clinical signs of respiratory distress, abnormal vital signs. How do you see abnormal vital signs? Tachycardia, tachypnea, hypotension, decreased pulse saturation or pulse oximetry, temperature. These are abnormal vital signs. Central and peripheral cyanosis, pursed lips, especially patients in COPD, grunting sounds, patients who are aspirated or patients with stridor or foreign body, they can present you with grunting sounds. Nasal flaring, this is a sign of increase or decreased oxygen level inside the body, and the body is doing as much as they can to take as much air or oxygen inside the body. Intercostal retraction, especially you could notice in a patient and child who are with history of upper respiratory tract or lower respiratory tract infection or pneumonia can present to you with intercostal retractions. And what does that represent? Impending respiratory failure. Use of accessory muscles, again. Abdominal breathing. Patient is using abdominal muscles as well to take more oxygen inside and to help to relieve the respiratory distress. And paradoxical motion of the chest. With inspiration, abdominal contents go inside. With expiration, abdominal content go outside. So this is paradoxical motion of the chest. So diagnostic testing in patients with shortness of breath. ABGs, very, very important. What to look for in a patient with ABGs? First, pH. Is the patient acidic or alkalotic? Next, PCO2, partial pressure of carbon dioxide. If it's more than 45, think of patient is retaining carbon dioxide. If the carbon dioxide is less than 45, think of patient is excreting more carbon dioxide. That might be due to a respiratory compensation of the metabolic component, but also this can be presented in patients with shortness of breath. D-dimers. D-dimers are important, especially in pregnant females, where CT scan or radiological studies are not allowed or not advised because of increased risk to the baby or to the fetus. D-dimers at times can tell you or estimate or tell you a close diagnosis if the patient is going to pulmonary embolism or not. BNP, B-type natriuretic peptide, especially in patients with congestive heart failure. Increase in more than 100 is said to be a sign, is said to be a diagnostic in a patient with congestive heart failure. But less than 100 has increased suspicion that the patient is not having congestive heart failure, or increased predictive value this patient is not having congestive heart failure. BNP is important in a patient with congestive heart failure and present to you with shortness of breath. And on auscultation, you see a crepitations bilaterally. There's peripheral edema. Think of acute onset of congestive heart failure. BNP is a test to be audited and to see if this patient is having congestive heart failure or not. White count, signs of infection. In MI, there is increased signs in white count, but there is increase in white count in patients with history of fever, shortness of breath, and temperature. What do you see? What do you look for? Signs of any upper respiratory or lower respiratory tract infection, signs of any pneumonia. Hemoglobin and hematocrit. Decreased hemoglobin can present with shortness of breath. Dehydration, hematocrit more than 35 can present with shortness of breath. Electrolytes abnormalities, they can present with shortness of breath. Glucose, especially in patients with diabetes. Why is glucose important? In a patient with, let's run a scenario. You see a young patient who is known case of diabetes, type 1. He comes to you persistent vomiting. You check on the blood sugars, it's more than 600. You do the ABGs, you see there is decrease in pH of 7.0. Bicarb is less than 15, that's for example 6. So what do you interfere in this patient? Metabolic ketoacidosis. This patient is diabetic ketoacidosis. This patient needs treatment. On the other hand, patient with type 2 diabetes can present with hyperosmolar hyperglycemic state. They also can present with shortness of breath. So glucose is important. Pregnancy. Not just because we have to protect the patient from radiological studies or the drugs that can be given or can be fatal or can be worse, can be worrisome for the fetus. It's always about the pregnancy can cause pulmonary embolism, so they can present with shortness of breath. PT and APTT, liver function tests are important in diagnostic testing with patient with shortness of breath. Blood cultures and sputum gram staining. Blood cultures are important in patient with fever, and sputum production and sputum staining is important in patients who produce sputum. So sputum production can be a sign in patients with new onset of tuberculosis or history of pulmonary tuberculosis or acute and reinfection of tuberculosis. Chest X-ray, as you can see in this patient, this is a portable chest X-ray. As you can see in this diagram, there are multiple infiltrates and there's increased haziness bilaterally. So what does that mean? These are the pulmonary vasculature and they're going up, down. It is called cephalization of the pulmonary vasculature. And this itself is a sign of fluid overload or fluid in the pulmonary system or congestive heart failure. On the other hand, as you can see here, there's unilateral infiltrates and there is no infiltrates on the right side of this lung. So what to expect? This is pneumothorax. As you can see, the lung parenchyma is over here. This is the pleural space. On the other hand, you can see this pulmonary vasculature. So this is pneumothorax. As you can see in this diagram, on the left of the X-ray, there is increased suspicion of cardiomegaly. So ECG is very, very important. Why? To rule out acute myocardial infarction, new onset of atrial fibrillation, any dysarrhythmias that are going inside, or any other heart abnormalities that can present with shortness of breath. CT chest or HRCT, high resolution CT scan. This can tell you a very, very important and a very detailed knowledge of the patient, but coming to you with respiratory symptoms. For example, as you can see in this patient, this arrowhead, this is a sign of pulmonary embolism. As you can see, this is vasculature which has been contrasted efficiently with the contrast. On the left side, there is adequate flow, but on the right side, there is this grayish discoloration, and this is a sign of pulmonary embolism. And this is a massive pulmonary embolism. So ventilation perfusion scan, it's not widely used, but it's recommended. So this upper head shows the perfusion scan, and the lower row show the ventilation scan. Although these are very, very important, but this is not as much important as to maintain the airway in emergency department. Diagnostic testing is important, but first you need to stabilize and to address the life-threatening problems in a patient in emergency department. So echocardiogram shows the level of ejection fraction, any valvular heart diseases, pericardiocentesis or pericardial effusion, any recent MI, decrease in ejection fraction, any wall motion abnormalities. These are seen on echocardiogram. So, in the end, I would like to summarize what we have studied till now. The topic was under discussion was how to approach a patient with shortness of breath. So when you see a patient with shortness of breath, what to look for first? Is the airway patent? As the pulse oximetry shows oxygen more than 90%. And if it's not, you have to treat that thing first. How do you treat the patient with shortness of breath? Oxygen supply, and oxygen supply. Oxygen via mask, oxygen via non-rebreather, oxygen via nasal cannula, oxygen via an NIV, non-invasive ventilator, which includes CPAP or BiPAP, or mechanical intubation. Do whatever you can to maintain the airway. You have to maintain the airway. Then look for the cause of the diseases, of the shortness of breath. We studied what might be the cause of shortness of breath in patients who have a previous history of any diseases that are related to respiratory system. For example, asthma, COPD, congestive heart failure. We studied about patients where we talked about what might be the differential diagnosis in a patient who presents to you with fever and respiratory distress. Patient who present to you with abnormal breathing sounds, stridor. We then studied what are the history questions one should ask in a patient to get to the diagnosis, or at least to narrow down the differential diagnosis. And what is the significance of those questions? We also studied the red flag signs of patients presenting to you with shortness of breath in emergency department. We then studied some of the signs and symptoms and clinical signs, what we can expect in a patient with shortness of breath and what we could see in a patient with shortness of breath. Then we studied about some of the simple or general lab investigations that could help us to get to the diagnosis, or to help us to review the therapy that we are giving, which includes arterial blood gases, complete blood count, hemoglobin, hematocrit levels, chest X-ray, HRCT to a pulmonary embolism, D-dimers, pregnancy tests, and much more. So this is all for now. Thank you for watching.